two. Perfect. Thank you. All right, Ryan, Angelo, you all just let me know when you're ready for me to get started.
I think we're good to go.
Fantastic. All right. Thank you all for joining us today for our very first clinical leadership slash clinical training webinar. We're going to be doing these monthly, and my name's Shelly. I'll introduce myself in just a few minutes, but I know that this is the first time I'm meeting a lot of you all. But like I said, our general agendas, we're going to go through a few slides here, and then we will have plenty of time for a Q&A at the end. So that being said, let's just start off with an introduction of our clinical leadership team. So, first off, I think it's really important to talk about the mission. So, our mission as a leadership team is really in supporting clinic as an organization at whole. That includes our care coordination team, which is really awesome, and all of the other departments. And of course, you all, our provider network, which the magic cannot happen without you all, with delivering easy access to outstanding care so that patients can achieve meaningful recovery or relief from a variety of conditions. For right now, opioid use disorder and mental health conditions, but I'm super excited to announce that, more and more things will be coming online. So, more about that in future webinars to come. But that is our overarching mission, is to support you all and the org so that we can bring patients in and get them on the path to relief. Now, our leadership team is composed of a lot of different individuals. So Ryan is our director of operations, and Lacey, I'm sure most of you all have met Lacey in some form or capacity. She is our fantastic chief of staff. And then Jen, I can't say enough things about you. I know everybody in this room knows Jen. She is our provider success and education guru, but I really feel like she's the glue that kind of is the go-to for everything at this point. And um, she's gotten us really to where we're at. So can't thank her enough. We do have Dr. Ursani. Some of you all may also have him as a collaborating physician. He is our chief medical officer. I am not sure if he's in the meeting today. And then we also have Dr. Saba Hawk. I'll call her Dr. Saba. I could have absolutely just butchered her last name if she's watching this recording later. I am so sorry, Dr. Saba. I've actually never said your last name out loud, but she is our medical director, and also for a lot of you all, she serves as a collaborating physician. Um, Mandy, who I'm going to have introduce herself in just a moment, is our psychotherapist consultant, and she's also a licensed clinical social worker. And she's going to be part of a very important launch that we're going to discuss in just a minute. And I'm Shelly. Now, Nora is my legal name, so you may see it Nora. I'll answer to either Nora, Shelly, whatever. I am the lead provider. I like to refer to myself as the OG provider, and that's because I've been here at clinic since the doors have opened. So I do kind of a variety of behind the scenes things. Some of you may have met me before, or I've had a patient that I may have seen for you, or you may have taken a patient transfer from me. But I have been here for a very long time. So a lot of what I do is involved with helping to get new service lines up and running, and sitting in on those types of discussions about where we're going next, helping with the standard operating procedures. And then I also see patients. So I feel like it's really important when we're launching service lines that I'm out there doing the work as well. So I carry a relatively full panel, and am doing the work right alongside you all so that I can understand the pain points as well. So that's a little bit about me. Can we go ahead and go on to, oh, by the way, I'm a nurse practitioner. By the way, I'm not a doctor. Been doing this for about 10 years. So if we can pop to the next slide. So, first off, we have a really exciting announcement, and that's that therapy is launching soon. And for that, I'm going to mute myself for just a moment, and I'm going to let Mandy introduce herself in just a little more depth and talk just a little bit about the therapy launch. But I don't know about you all, but I'm super excited that we're about to be able to offer this service to our patients.
Thank you so much, Shelly. Like she said, I'm Mandy, and I get my chops mostly in New Orleans. I see folks who are in the industry usually music or restaurant industry. So a lot of the themes that we go through here at Clinic, especially the mission about easy access and getting to people where they need it the most, is something I'm really on board for. Um, Therapy is something that I think people need while they're in recovery, but we find that once someone is really starting their journey back to health, they need to talk through things. So I think Clinic is really wise to start to think about therapy as an offering, and I'm part of that, which is really exciting. So as this unfolds, we're going to launch in Virginia first. We're looking at hopefully starting to get some folks who take us up on medication and therapy and other supportive services all through Clinic. And we're hoping that that'll launch as soon as May 1st. So if there's any questions or any other referral stuff, I'll give some more formal communication. But feel free to chat me. I'll put a link in this Zoom by the end of our call if you need more information for your patients about therapy, okay?
Awesome. Thank you so much. And if we can go ahead and go to the next slide. All right, I've got a quick clinical reminder for my multi-licensed providers, and I've just thrown up a test patient here from Dr. First. So this is from my Dr. First, but this is a test patient. So if you do have multiple licenses, just keep in mind if you're seeing a patient that's not in your default state, my default state is California. So wherever I'm seeing a patient at that moment, I need to go up to that little corner on the right hand and hit the little drop down beside Virginia and then pick the correct state. Um, Now, some of you may not have had problems with a non-controlled substance bouncing back. So say if you send in an ondansetron, but what we've noticed is because each state has that office location tied to it, if you try to say sending a Suboxone prescription from Ohio to a Virginia patient, you could cause issues at the pharmacy, especially you all know that a lot of these pharmacies have really stringent guidelines about how far the office, the actual physical location that clinic has is located from the pharmacy of choice. So that's where this really comes into play. But also, if you've ever accidentally sent it from another, if you pull up the patient's history or say like you started to fill out a prescription and you realize, oops, wrong state, and then you toggle to the right state while it still says on the correct patient, that information that you were just that hard work you just put to put that prescription in is now erased. So if you haven't hit send already. So just as best practice for any of my multi licensed providers, just make sure that you're on the right state to begin with, just to prevent a little heartbreak later in the process when you have to go back and correct it. So hopefully that makes sense. If not, you can definitely ask me at the end of the webinar and I can hopefully provide some clarity. All right, can we go on to the next slide, please? So this is going to be the bulk of our presentation today. I'm going to start in the chat. I'm going to share a document with you all that you can click on and follow along or save. Please do save for your reference. Now, this is a living document, and as we make changes throughout, the reason why you have viewer only access is I don't recommend that you print it. Well, you could, but you want to check back frequently to see if there are updates because there will be periodic updates as we refine things. As always happens in medical care, we refine things as we go along. But I want to start off with this general psych launch with saying that I know we've already given some general education, but we just wanted to revisit this and give some tips and tricks and hopefully get more people comfortable with the process so that we can really fully launch this and offer this to a larger subset of patients. Now, I am really big in taking accountability. So I want to start off by saying, you all, I know that Monday morning, a lot of you woke up and started seeing patients and you noticed that that note had changes. Now, that was my fault. And I apologize deeply. I made the changes at night on a Sunday night, very late, where I thought that there would be very few people charting. But what I failed to do in retrospect was to send out a communication to you all warning you that for existing patients, we would be having to use the cut and paste option. So I apologize. I take full responsibility, and I'll make sure in the future that whenever possible, we are communicating these things ahead of time and giving you an approximate of when these changes will go live. Now, as I know, I said before, I see a full panel of patients. Monday, I saw over 20 patients. So I feel you in that the existing patients that we have, it does feel a little cumbersome to copy and paste. Now, all of our notes have previously been like that. There have been small sections you've had to copy and paste. The thing that I'm pleased to tell you all that I hope that will be exciting is, you know, Clinic Medical is relatively young in our, what we hope to be forever clinic, right? And your forever practice home, hopefully. But that I have rigorously tested all of these notes now. And for your new patients that come in forward, we should not have the same issues with copy and paste. Things should flow like butter. So while I understand that there's a small pain point, I'm not going to say it depends on how big your panel is. There is a pain point with that first time with copying and pasting. In the end, this is going to be a really positive change that's going to speed things up and keep consistency between the notes. So again, mea culpa, I am so sorry I didn't communicate that beforehand. Lesson learned, I will make sure to over communicate next time as we do look at some of the other changes you all have asked for in the past and gone through to see what we can implement to make sure that our documentation has continued to be as thorough as possible, but as streamlined for the providers as possible. So on that note, we want to say that with general psych, we want to make sure that we're offering this service. And I wanted to talk just for a minute about identifying good candidates for services, like who we should offer this to. Now, we'll talk about this in just a second, but bipolar is not going to be something that we're able to treat under general psych. That is going to go to our specialty psych, which we'll be launching hopefully sooner rather than later. We'll send out communications and what the process will be to get your patient to that area. But just in thinking about who could we offer general psych consultations to, this might be a patient that comes to you and they've got a very high PHQ-9 or GAD-7 score, or they endorse to you that they've previously been treated for anxiety or depression or insomnia or PTSD or any number of things. And right now they're not treated, which we know a lot of our patients, they come to us and they're in a spot where they've been neglecting their mental health, or they just weren't ready. And now that they're entering into recovery, now is a good time to re-engage services. So thinking about those patients. Now, patients that we really aren't going to be able to service quite at this moment are going to be people with the specialty psych diagnoses. So like bipolar and some of the diagnoses that are what we call on the psychotic spectrum, right? Schizoaffective, schizophrenia, et cetera. That's really going to be more of a psych specialty thing. We want to make sure that we're keeping people in their scope of practice and that we're practicing to our fullest scope, but that we're not exceeding it. So, safety for your license is always tantamount. We'll come back to this in just a second, but I just think it's really important to know that a lot of our patients don't know that we offer psych and that it's important that we're identifying those people. You may also hear, sometimes I hear patients say, yeah, I've got a provider and they're prescribing me, X medication, maybe Zoloft. I like to pick on Zoloft a lot, but it doesn't really feel like it's doing the job, or it's not really working. I take it half the time. You could ask them, would they like to talk to you further in depth about maybe switching medications. So I'm gonna go ahead and leave that at that, and we'll come back and circle to this bipolar issue, or what you do if somebody has bipolar or schizoaffective or et cetera, in just a second. But to get an existing patient an appointment, um, the they fill out a form. They fill out the KM existing patient general psych pre-appointment form. And the simplest way to get this form to your patient would be care coordination to send it. So to give you an example of how I might script this, I might say, okay, great. I think that I can see you and absolutely help you out with this anxiety. There is a very short form that I need you to fill out. I'm going to ask care coordination to send that to you. It's not very long at all, but it's going to help streamline our appointment. And then once you're done with that, just contact care coordination back. You can either text them or you can call them using the number that they use to confirm your appointments, and then they'll be able to get you scheduled with me. Some of you all are more comfortable with the system and you feel comfortable in like sending, for example, the GAD-7 and the PHQ-9 monthly. If that's you, you can actually send this form to them yourselves. It's done the same way as you send the GAD and the PHQ-9. If this sounds foreign to you and you don't know how to do it, I would recommend that we don't. I recommend that you leave it to care coordination. And the way I would handle this is you do want that appointment form, that pre-appointment form filled out prior to you actually doing the visit because it's going to save you so much time. So what I would typically do is if I was going to send this to my patient, I'm going to already have a 1-week follow-up for their MAT appointment. So at their MAT appointment, I would just click over into forms and I would see if they had filled it out. If they'd filled it out, I'd say, great, I see that you filled it out. I'm going to go ahead and finish with your MAT appointment today, and then let's go ahead and get you booked with me for your initial psych visit. So that's how that flow goes. Now, I'm going to switch over for just a second to our general psych tip sheet for a moment. I'm not going to read this whole thing to you because I trust everybody in this room can read, and we want to make sure that we keep this really high level and brief. But I am going to give my Calendly link so that if you feel like you need some one-on-one time with me to go over this or get any more questions answered after our Q&A session, that you've got time to do that and that I'm supporting you. If psych is a little bit dusty and rusty to you, I can tell you the Stahl's Essential Psychopharmacology Prescriber's Guide is awesome. I have the 6th and 7th edition. The 6th edition I've got right here. It's my loved edition. I don't find very much difference between the two of them, and the cost difference on Amazon is kind of significant. They do make the Kindle version, but something about me, because I'm a little bit older, I like the being able to touch and tab, etc. I think the 6th edition is just as good. There's only a few medications that are not in the 6th edition that made it to the 7th edition. And those are typically not ones that I use a lot anyway, usually because they require pre-authorization. And for the most part, they're just as good medications that don't require pre-authorization that we have a longer history on as far as, being used in clinical practice. Now, when you see this patient, it's important to know that when you're doing an initial psych intake, the GAD-7 and the PHQ-9 scores need to be updated if they're older than 14 days because we're looking at the last 14 days. And when you're classifying, let's say if they have moderate depression, whether it's recurrent or whether it's, initial episode, that we're able to get the severity right, based on the PHQ-9. So I would say that if you're less than 14 days out, you're good to use those old ones if you're able to get them in quickly after that initial visit and they've just filled it out. But if they're older than 14 days, I would just take the time to go ahead and quickly get them filled out. The insomnia severity index, this isn't healthy. If they are complaining of insomnia, I would get a baseline score from them. But per Dr. Ursani, who is our medical director, our chief medical CMO, my apologies. We don't necessarily need to keep doing it. It's more useful in the beginning as a baseline, but really clinical response is what's more important afterwards. So I consider that a one and done as of right now. I also recommend that you check the PDMP on every patient, even if they're non-MAT. Now, we will be having some patients come in just for psych. I'm already seeing a few, but you also might start seeing them on your schedule. They'll be scheduled for an hour-long intake, just like a regular MAT patient is. But you need to know what else the patient's on, right? What could potentially conflict. If I'm going to put them on some medications for insomnia, I certainly want to know what do they already have a prescription for Ambien? Even if I'm not going to touch them with a controlled substance, because obviously right now the only controlled substance that we do is Suboxone. and then gabapentin in a couple of states where gabapentin is considered a controlled substance. I also highly recommend that you use the check medication history in Dr. First. If you don't know how to do this, I've put a screenshot, but it's near the top, and you can do 3 months, 6 months, and a year. This is really useful for those patients who cannot remember the medicines they've been on in the last year or what dosages they were on. So it helps give you a quick snapshot, and I've put that in the document. So those are just some quick little pearls. Now, I told you already about the bipolar thing, but let's talk about that in a little more depth. Unless a patient is intoxicated or psychotic, if they get scheduled with us and they shouldn't have been, we should go ahead and honor that visit. Complete it as a billable visit, get all of the info, and then you're going to let them know that we need to refer them, that we're not able to service them at this time. And that's going to look like a couple of different things. Once we have psych specialty up and running with our psychiatric nurse practitioners, we'll be able to say, hey, while this is something that I don't manage, I'm going to continue to do your medication assisted treatment, and then I'm going to get you referred to one of my colleagues who's a specialist so that they can help treat this condition that you've told me about. And the good news is, because we've already done this visit, your next visit with them is going to go a little bit smoother because they've already got that history to look back on. What that will look like is you will send a note to care coordination just saying, hey, this person needs to go on the psych specialist waiting list. And care coordination will also, until we get that up and running in all states, will be able to give them local referrals as well. So we're not having them just wait and wait and wait. Now, to be very clear, you can still absolutely see these patients for medication assisted treatment. Please don't stop somebody's Suboxone, except under that rare circumstance that we need to give a bridge or we need to get them to a higher level of care because they're acutely psychotic, right? Bipolar patient can absolutely still see you for MAT. I didn't mention this earlier, but this just jogged my memory. Have you ever had a patient that you come in, you put on comfort meds and the mirtazapine or the hydroxyzine, they said, oh, that really helps with sleep, and I would really like to continue that medication? These are also good patients to get in for psych because maybe they have some undiagnosed insomnia or opioid-induced sleep disorder. So those would also be great candidates because you want to make sure that the work that you're doing is being captured and that we're also getting adequate information on what diagnoses the patient has to keep that on our chart. Now, bipolar is a contraindication to all non-MAT or SUD treatments, right? SUD treatments. That includes anxiety, insomnia, whatever it will be. So, and there's a reason behind that. Something that we give them for insomnia could very well exacerbate their existing bipolar. So, even something as simple as mirtazapine longer term could be detrimental. So we want to make sure that they are seeing the right level of care. However, if they do get scheduled with you, complete a billable visit and evaluate. And remember that some people self-diagnose themselves as bipolar, or they've heard in passing that they have bipolar through another group, a friend, they've somehow gotten in their mind that they have bipolar, but they truly don't. So an MDQ can help flush out if bipolar is likely versus whether it was a false diagnosis. Now, if mania is associated with drug use, then I highly suspect for incorrect diagnosis. If somebody did a couple of lines of cocaine and then got hospitalized because they were talking a mile a minute and they were driving 120 miles an hour down the interstate, that's, could very well be intoxication with stimulants as opposed to a manic episode. Consider their clinical history. If you talk to them and they say, I've been on Lexapro for years or fluoxetine for years and never had any mania, and they've not been on any atypicals or any of the stronger atypicals, then consider that perhaps their diagnosis might have been incorrect, or that they've somehow internalized that they have bipolar because they quote unquote have mood swings. However, If there's any question of accuracy, err on the refer to psychiatric specialty rather than risking worsening a clinical condition. I hope that that's super clear. But we want to make sure that we're evaluating everybody that's appropriate. And again, it's going to help them when they get to psych specialty because they've already had the visit. Now, I know it's not um, comfortable to tell a patient that after they've done a visit that we can't treat them ourselves, but it's just getting that verbiage and that scripting together in your head to explain that you're doing it because their safety and making sure that they're at the right level of care for their condition is of utmost importance. And again, care coordination for right now until we have this up and running can help with referrals to psych care while we're waiting for specialty to come online. All right. Now, a couple of really important points. The initial appointment for psych is always separate from MAT, cannot be on the same day. This is for insurance purposes. Now, follow-ups can address MAT with prior provider discretion, but I suggest you only do this on clinical stability or if you're having a really hard time getting them in for visits. Keep in mind that a typical follow-up for a new psychiatric patient is going to be about 14 days after you start a medicine. Now, we're still seeing them from MAT weekly in the beginning. That's our standard of care. Even if they've been on Suboxone for 7 years with somebody else, they're still new to us. So we're starting off with weekly. I would typically see them 14 days after I start a medicine and after dose changes, but I would then quickly move them to monthly once I feel like they've achieved some clinical stability because I'm already going to be seeing them weekly and seeing how they're doing with their MAT diagnoses. Now, for the patients that aren't MAT, that's going to be a little bit different. That's going to be your discretion. There are occasionally going to be patients you need to see in a week because you need to make sure that they're taking their medication or they're not having a clinical deterioration. Your typical follow-up is, again, 14 days after initiation or dose changes. You can move to 3 months at provider discretion, but I highly recommend that you wait until 3 to 6 months of stability. And when you're seeing a MAT patient and a psych patient at the same time, so they're a dual diagnosis patient, you want to make sure that you're not getting too far out from the good rule of thumb is making sure once a month you're doing that psych follow-up form because that asks different questions than the MAT form. So I did go ahead and add in on the follow-up visit, the psych follow-up visit, that you can actually address SUD at the visit. So MAT for right now, although that will expand in the future. So if you hit yes, it will drop down and it will carry over an HPI. This is one of the few times where you may have to cut and paste that first visit, what their HPI looks like, but in general, I don't think that you'll have to. So just knowing that in general, we want to keep these appointments separate, but I do understand as a clinician and as some of our patients have difficulty making appointments anyway, there are going to be times that we have to, at a follow-up, do a Suboxone refill. Okay. But if you're doing a monthly visit that's just psych, again, not the same day as a MAT follow-up. All right. Existing MAT patient or follow-up. So I've put in here what our chart templates are. Please note for that first one, right now we use KM existing patient initial psych visit. I am going to be changing the name at some point to make all of the nomenclature match. So it's going to use this one, KM initial psych visit MAT patient. So everything's going to say initial or follow-up and then MAT or non-MAT, but I will warn you all. I will send out an email with when that change is going to go live, but I do want the templates to all have the same nomenclature once we get to that perfect state. All right. So I hope that that's super clear. I'm not going to read to you what these follow-ups are, but they all say use this one. And there's initial and follow-up, and then there's MAT and non-MAT because you will start to see non-MAT purely psych patients on your schedule. Now, I'm going to talk just a little bit about billing, and then I'm going to wrap this up because I don't want to talk you all to death when you can read this and when you can schedule one-on-one with me. But typically, something that we have noticed is that the billing codes confound some providers. And we've tried to make it really clear with the note drop downs, and Jenna's put in, what constitutes a level 2 versus a level 3 versus a level 4. I will tell you, I'm almost always use a level 4. There are a few times where I'll use a level 3, but I'm going to talk you through it really quick just in case this is something that still kind of escapes you. All right. A level 4 visit can either be billed by time or complexity. So, when, and this is a really important point to make too. If you see a patient for an initial psych evaluation, but they're an existing patient, meaning they've seen clinic in the last year for MAT, or maybe they were psych and they went away and they came back and now they're on your schedule, they are still follow-up. It doesn't matter that you're doing a new service line, and it actually doesn't matter that they're new to you. Most insurances have really strict guidelines about how often we can bill a new patient visit. So if they've seen clinic in the last year, you're going to want to use a follow-up code. You can ask billing if you have any questions about that, but that's the consensus. And that's one of the biggest things that we're seeing right now is that you're seeing somebody for an initial psych, even though you've already seen them from MAT and you're billing it as a new patient. They're not a new patient to you. They're most likely going to be a level 4, right? So level 4 is fairly easy to get to. Number one, either the diagnosis is exacerbated and you're looking at a score, so PHQ-9, a GAD-7, an ISI, and the diagnosis is exacerbated if it's not treated, if it's not well managed, if their PHQ-9 is above that absent to minimal, or if that GAD-7 is above that absent to minimal threshold, it's exacerbated. They're also a level 4 if they have 2 or more diagnoses. Let's say they've got a depression diagnosis and an anxiety diagnosis, or they've got a depression diagnosis and they're a nicotine user. If they're a nicotine user, even though you can only bill that nicotine cessation once per year, at every visit, you should be asking, hey, are you still using nicotine? When it asks you what substances they've used, we should absolutely be listing nicotine, and we should be saying, do you have any desire for smoking cessation? And then we should say, one of the best things that you can do for your health, other than taking care of your mental health or your, continuing with Suboxone, is considering stopping smoking or stopping vaping, etc. That constitutes that you address that diagnosis and can click it in your visit. You're not billing for education because you're not necessarily doing 3 to 9 minutes of counseling right there, but you've addressed it at the visit, and that absolutely gets you those 2 diagnoses. Now, if you have to address OUD in a psych visit, like providing a Suboxone refill, then you absolutely already met the threshold. So you addressed 2 things. Just make sure that you check off that you addressed the F1120 or whatever diagnosis it may be. Maybe it's opioid use and remission, whatever it is. You just make sure you check that one off in your visit note. And if you spend more than 30 minutes in a follow-up, then that's billing strictly by time. And remember, it's not just 30 minutes in front of the patient. As long as it's the same day as the patient encounter, you're talking about time reviewing the PDMP, time reviewing the past notes, time looking at the GAD-7 and the PHQ-9 and the ISI in order to prep for the appointment, time drafting the prescription and sending it. All of that counts as time as long as it's in the same visit. Now, if you wait until the next day, that is not going to count, right? If you do it the next day, then it's you're not going to be able to use that whole thing. I would recommend you go by complexity. A level 3 is rare for an existing MAT patient. This would be when that whole time lasts 29 minutes or less and only one diagnosis is stable and addressed. So the best example I could give you is if somebody comes in to see you, they're a quote unquote easy patient. They say, hey, I've been taking Zoloft for 3 years. I love my dose. I just think it would be more convenient to see you than my PCP. And it only takes you 25 minutes to do everything. That's going to be a level 3. So now our new to clinic patients, so these are non-MAT patients. So it'd be very rare you ever get a MAT patient that has a psych visit first. That ever happens, It would usually be in the context of somebody already has a Suboxone prescription and they're just switching providers, right? And so they've got, they're kind of waiting to get their prescription filled. But if that ever happens, you use the initial MAT template at the next visit so that you can get all that information that's not captured on the psych visit that you need to get. And you would need to do some copy and pasting. But my hope is that that's a very rare, almost never event here. They would usually come in as MAT because MAT is usually the most pressing thing. Okay, so those are your chart templates to use. And remember with the billing here, so this is where we use the new patient visits. So 99204 initial psych only. So low threshold to get a level 4 here. You spent 40 minutes or more, again, reviewing things, the PDMP, writing the prescriptions, or even just looking at their past medication history. Or the diagnosis is exacerbated, or there are two or more diagnoses like depression or anxiety, right? So that gets you to a 4 very easily. Number 3, sorry, a level 3 is going to be super rare. You have to meet 2 qualifiers here. Number 1 would be your total time spent is 39 minutes or less. So the patient's not a fit for practice. So your intake is relatively easy, relatively quick, and you're not spending a lot of time doing the education with the medication and the risks and benefits. It's because we can't treat them right now. So you would have to do that. And the final diagnosis is not exacerbated. So let's say this would be a patient that comes to you. They're bipolar 2. They're stable. They've been on Latuda for 6 years with their primary care or with some other provider. The visit goes through very quickly, very smoothly. We have to refer them to specialty psych, but there's nothing else. Even if they are a smoker, you are going to document that they're a smoker because it does ask you because it's an initial visit. You're going to do a 3-minute or more nicotine cessation counseling, and you're going to be a 99204 right there that easily because you address 2 diagnoses in the visit. Okay. So that is a quick primer. And again, I've written this all out in painstaking detail on that document for you all. And I'm so happy to do a Calendly, which I'm going to throw in the chat in just a minute for you all to talk to me about this one-on-one if it's still fuzzy, because I get it. It's a lot of us have never had to think about coding before, as far as like the visit complexity, etc. So I'm happy to break it down further, but I hope that this is helpful once you give it another read through. All right, really quick, how to get an existing MAT patient to a psych appointment. Email care coordination with a link to the patient healthy. Ask that they give that pre-appointment form that I referenced earlier, and then get them scheduled with you once that form is filled out. How to refer a patient you see that's not appropriate for care in general psych. So you see them for your initial visit, or they request psych in their MAT appointment and they have bipolar or other rule out that you think is not appropriate for general psych. You're going to email care coordination with the link to the patient healthy, ask that they get waitlisted for the specialty psych and given resources for referral for psych care in the meantime. Continue them for MAT unless they are acutely psychotic or otherwise, for some reason, as listed in our SOPs, not fit for service. So I hope that that's all helpful. Let me go ahead and post my link to Calendly, and then I'm going to look over just really quick. I did address the diagnosis codes just very briefly, but remember we use DSM-5 criteria. If you don't have the DSM-5 book, you don't need to go out and buy it. You can very easily go and look up what's the DSM-5 criteria for major depression or PTSD, etc. Jen's also done a really great job of listing out when it says, those check boxes of what are you doing, depressive symptoms, PTSD symptoms. I mean, that's almost the entire work of it there. There are just always some little provisions on how many months has it's persisted, etc. I do want to caution you against using the not otherwise specified diagnosis unless you absolutely can't drill it down further. Insurance doesn't love the not other specified NOS, but sometimes we have to use it. So if you can't nail down what kind of anxiety it is and the clinical picture is unclear, you could use anxiety unspecified if you otherwise can't get it to meet the DSM-5 criteria. Okay, here's my Calendly link. I will be putting more dates on there, but there are definitely some for next week, and I believe a couple for the week after that you can schedule with me. if you're really having difficulty finding something that fits your schedule, I do work all kinds of hours, so you could just reach out to care coordination and ask them if they could get in touch with me to see if there's another time that we could get scheduled. For right now, we'll leave it at that. And yeah, I think that that's all from my presentation. Angela, if you can go ahead and flip it to the next page. We're going to do a Q&A, but Jen and I are going to tag team this because this is not necessarily just related to Psych Launch. This is a Q&A for you all since this is our very first webinar together. So some questions I may defer to Jen and some may be more for me. So with that, we'll go ahead and open it up.
And Shelley, you said it's a general question, not only pertaining to this webinar.
You can absolutely ask a general question and I'll just tag Jen in.
Okay, so I think the issue that I'm having right now is during the induction period when the patient doesn't have the induction instructions. So it's very difficult if you are trying to explain to the patient, especially when they are very naive patient. It's so difficult. Sometimes I ask them, well, they sent you the instructions ahead of time. You can check, but it doesn't happen quickly. Sometimes in two days, you see the instructions appearing on their healthy chart. You can see it. So I don't know what is the quickest way for them to get access to the induction instructions.
That's a great question. I can take that one. It's actually in what they sign up. So if they look in their documents, now I'm going to be the first one to admit not everybody's tech savvy and they don't know how to look in their documents. So if they can't find it in their documents, care coordination could actually send them the link if they had to. Now, we want to be careful about how much stress we're putting on care coordination with doing extra back and forth, but we do want to make sure induction's a very sensitive period. Induction can make or break whether a patient ever comes back to us for that second visit, because if they feel like they went into precipitate withdrawal or that the medicine's not working. So I would say if all else fails, but it is in the documents they signed up. And so if you can ask them if they know how to get to their documents, it's right. And it says the instructions for starting Suboxone. I can also tell you in clinical practice, I tell them, I walk them through just a very simplified version. Is that, after you have 4 more symptoms and they're feeling pretty moderate, go ahead and take a small piece of your strip. If you're not feeling better in 30 to 60 minutes, take another small piece, but don't. So you kind of internalize those instructions too. But I understand a lot of those patients are throwing up. They don't feel good. They're not really listening. So the key is trying to get them to their documents, and an absolute last minute would be asking care coordination just to text them the document only on the house so they can read it over themselves. Okay, I hope that helps. Anybody else? I feel like I don't know if the quiet is that I've explained it so well and that document is so easy to follow, or if everybody just needs a moment because I've blown your hair back and you just need to chew on it for a little bit. If it's the latter, which I suspect because we just went over some really complicated things quickly, again, I'm absolutely happy to meet with you all after you've had a second to let it digest, but sometimes it just takes reading it again too. So
I had a question. In terms of the general psych visit, I haven't started seeing patients yet. I anticipate doing that in the next couple of weeks for MAT services. But I didn't get a walkthrough for the psych documentation. Is that somewhere where I can sign up for, one of these sessions where they walk through that like I did with the Suboxone visits?
Jen, I'm gonna punt that one to you because I know you did the initial. I don't know if there's a video, but I will say this. I'm always happy to go over with you as well if needed. But let me give that to Jen for just a moment.
Okay.
Yes, thank you. Hi, Jennifer. I don't remember if I sent you the SOPs for the psych generalist, but I can definitely send that to you. Make sure you have a copy of that.
Okay.
And like Shelley said, we can definitely, I think I set up a test patient for you so you can look at those, go through the SOP and go through the templates on your test patient as well,
Okay.
to become familiar with those. But, Shelley and I are both welcome to schedule time with you to go through whatever it is you need to go through, to feel comfortable with that.
So when I met with you previously and you set up a test patient for myself and one of the other NPs, mine didn't show up. I haven't been able to find it, so I've just been like looking at other test patients. Does it matter?
It doesn't really matter what test patient you use, but I will go back and double check your test patient. I
Okay.
think I know why it's doing that. I think it's because the name is so common. So I'll change it to your last name so that so you can easily find that test patient.
Okay. And I guess the last question is, when do you anticipate, or do you have any ideas about Arizona launching their specialty psych? Because I'm dual boarded and I'd like to be part of that.
So we are launched in Arizona as far as a clinic medical state, but we can definitely talk with Lacey about getting you the availability to see those patients in Arizona as well for this specialty since you are dual certified.
Great, thank you.
Yeah, Jennifer, I'd love to actually get that started with you. So I will actually talk with, or I'll actually put something on your account. I'll contact you outside of this meeting.
Okay.
Once I get outside of here.
Great, perfect, thank you.
Absolutely. And then Ryan, if you'll just connect me too, so that we can look at the notes and everything. Awesome.
Of course.
Laura had a great question in the chat. We are gonna have reoccurring. So we're gonna have one of these every single month, and we're gonna have a different topic and a Q&A. And so I'm really looking forward to having this time and like having the clinical team be able to meet with you all. All right. Anybody else? I want to be super respectful of time because I thank all of you for taking time out of your busy day to come and join us.
Just really quick, I think we're gonna put together a calendar, everybody for everybody to be able to view where we are gonna have, weekly or monthly webinars with like the care coordination team, provider success, clinical, and I know you guys have office hours, I believe too, as well, a few times a week, so that you can see those as well, like so that you don't have to just wait for your email. I'll put together like a whole calendar so that you guys can actually view that.
Awesome. And then if we can, I don't know if there's a way to link like my Calendly and Jen's Calendly too, so that we can do the one-on-ones, or just make sure anybody that's here that you save my Calendly link, and anybody that's watching the presentation, if you can't see it, it's actually at the bottom of that document that's attached. So feel free to bookmark it, and you don't just have to reserve me for this. So anything in the future, you'll always use that link if you want to get time on my schedule.
I have just two quick things I wanted to follow up. I'm sorry, did somebody have something, Gladys? I think that was you.
Yes, a quick question. So I know with the MAT, we have the specific medications that we use under the treatment plan, like we have to use Suboxone only. With the psych, do we have to use specific antidepressants, or we can choose any antidepressants that we want?
That's an excellent question. So if you look at the back of the SOPs, there's an approved med list and a not approved med list. If I could give you any caution, and there's even a couple pearls back there. But if you can't find it, let us know. But it is on the back of the generalist psych SOPs. But I will say that just remember, if you're using one of the newer meds that requires a PA, then the PA, you've got to do that document. So if there's something that's a little older that can get it done, then I usually, unless you enjoy filling out PAs. So whatever for the patient, but a lot of times the newer ones, there's something that's just as good that's in the older formulary with fewer exceptions. But yep.
Awesome, thank you.
Just the two things I wanted to check in on really quick with everyone here. I know not everybody was at last week's webinar, but you should have seen an email come through, and a lot of you did actually reply to it. with this call through functionality so that you are able to reach out to patients using your cell phone. If you're not familiar with that, I can actually have you resend you the email, but we do now have functionality for a call through phone number. So basically, if you give me your cell phone number or whatever number you're going to use to reach out to patients, and you call the clinic main line once I input it into our system, you are able to, you'll be met with a prompt to enter the patient's phone number and then call through so that you're actually calling from the clinic main line and they don't have access and see your actual cell phone or personal phone number. It's a pretty easy and simple way to just like reach out to patients instead of kind of waiting on care coordination or having a middleman in the process if it's needed. It's also really great for no-shows. If somebody is not showing up to your appointment, you actually have a chance in that moment to call them. A lot of times it's a patient that forgot or they don't know how to, they're having difficulties log in. And so if you have questions on that, I need that. Is there an email I can send? Yeah, absolutely. I know Jen sent it out originally, but we'll re-forward it to the group. If you reply with your phone number, I can only use one of your phone numbers. So just give me the one that you want. And all you have to do is call the number, then dial the patient's number, and you're good to go. So I just wanted to see if there were any questions about that, reintroduce it again. We just launched it last week. So we'll re-forward it. And then the second thing that I wanted to say is Shelly and Lacey and Mandy, and I'm pretty new here to not only just a clinic as a company and organization, but to launching new services. And I think what you'll see is these SOPs and reference materials, they'll be consistently being added to and improved upon. But if you need something else, if there's something else that would help y'all, if there's something that we could provide or make, or if there's something that's not covered in these, please let us know. I mean, I'm happy to rework and reorganize some of these SOPs and reference materials if there is something else that's needed. So I just wanted to put that out there, that as we're building, I could use the feedback to kind of, yeah.
Awesome.
Ryan, I'm
Go
sorry.
ahead. No, you go ahead first, and then I'll finish that thought. I'll keep it in my mind.
The phone, is it already in effect? Because I tried calling the patient, it didn't go through the guidance that you gave, dial this and that. It didn't work.
Okay. I will check in on your number really quick. It should work. It's when you call the phone number, you'll call the main clinic phone number. And as long as your phone number is in the system, you'll hear a prompt that says, like, to dial out, press 1. When you press 1, it'll then ask you to, very important, first you have to use the country code. So 1, then area code, then the patient's phone number, and then the pound sign. And that's all in the email that we sent as well. So I'm not sure if it was something.
Yeah, it didn't work. I tried that. It didn't work for me.
Okay. So I've gone through this with a few people, and the problem that has come up almost every time, I think like 4 out of 5 times, is not dialing the 1 and then the pound at the end. So 1, and then area code, patient phone number, pound. I will double check on your phone number and make sure that it's in our system. And then I'll let you know to like try again. If you want to try again, that would work. And we can walk through it together too. I could send you a Zoom link or something.
Okay, and as you said, you're going to build up on the SOPs and stuff like that. Is there a way you can add any guidance with people on benzos? It's really something that I don't feel comfortable with. But if there's something that I should be doing on people who are on taking Xanax, there are some of them that are taking high doses of Xanax. And they are taking, their UDS is showing alcohol as well. It's kind of scary seeing patients with all these drugs showing on their UDS. So kind of, if you guys have anything that will give us a guidance onto what to expect with people who are on benzos.
Yeah, so that's a great question, Gladys, and I just would refer to you in the SOPs actually near the beginning, it talks about harm reduction and it talks about ASOM's actual statement about how in most cases benzodiazepines and concomitant other substance use should not rule out for treatment. It's always clinician based. You know, somebody tells you that they're taking an exorbitant amount and you really feel clinically uncomfortable. I would say that you can reach out to care coordination and ask if they would you know, if there's a possibility of a second opinion. But in general, I would really just recommend that you go back in the SOPs and you find where I reference that statement by ASOM and that you go in and read it, because documenting that you're doing something for harm reduction and that it's supported by ASOM is a very powerful thing in your charting, because we know that while there is a risk of respiratory depression, the risk of taking somebody off of their Suboxone and the risk of relapse and, you know, overdose or death is oftentimes outweighs the risk of them taking especially a small to moderate amount. But again, that's not meant to usurp your clinical judgment. But I would highly recommend reading about ASOM's position on that, which I did put in the SOPs. You can find it. It's towards the beginning. So just weighing that. It's always weighing, right? Like what is most likely to benefit the patient, what's most likely to cause harm to the patient. Almost 9 times out of 10, I would say pulling somebody off of their Suboxone is going to be more of a harm. We also get into this with alcohol use, right? Like counseling them that if they're already, you know, they're using alcohol, we have to weigh that, you know, what's the chance that they go into DTs, and reminding them that they can't just stop alcohol use. That's not something that, you know, if they start on Suboxone. So it's a precarious thing. The thing I want to say, right, we're right here at time, is that remember, if you're using that phone system and you do leave a message, I wouldn't use Clinic. I would say, hey, this is Shelly. We had an appointment today at 12. If you'd like to reschedule, please get in touch with care coordination as soon as possible. If you say that you're from Clinic and somebody else listens to that message, theoretically, they could pull up Clinic and see exactly what they're seeing us for, because we're really only famous for one thing right now. So I would just be really careful with any messages that you leave, or may even consider not leaving a message and let care coordination do the follow-up for reschedules like they typically do right now. You're just trying to catch them in the moment by calling, if that makes sense. So
Gladys, I did confirm that your phone number is in the system. So I'll reach out to you via email and we can jump on a quick, 5-minute call and I could just see kind of what's going on with your phone number. Does that work for you?
Yes,
okay.
Thanks.
Okay, sounds good.
thank you all for joining. It was so nice to get in front of a lot of new faces, and I'm looking forward to seeing you all more. Does anybody else have any final remarks before we call it?
I would like to do that. Is that okay?
Sure, go ahead.
Sure. I didn't say anything because I'm very, very new. I've not even started seeing patients yet. I'm still in the onboarding process. So I guess my question, most of you know, I was wondering, like seeing MAT patients at the same time seeing psych patients, is the schedule going to be different? Or let's say I have an addiction patient that I'm seeing for Suboxone, and that patient is also going through depression, anxiety. Is that appointment going to be for both, or I'll see them on different occasions?
Different days. So your initial evaluation will typically almost always be a MAT, so Suboxone. And then they'll have a second appointment for psych. It's not going to be a full hour long. You won't need the full hour. You'll already have a good sense of the history. And as I was referring to as we were going through, I know that was probably a little more nebulous for you since you haven't been in it, that if there's ever a time that you need to address, say you're doing a psych follow-up, so you've already done the intake and you're doing a follow-up, but we need to refill the Suboxone just because of the timing, there's a little checkbox you can use, and the questions that are related to the Suboxone will go down. But in general, there'll be separate appointments most of the time. So I hope that helps. Welcome, by the way. All right, everybody. I think that that's it. I hope that you have a wonderful weekend coming up, and I'm looking forward to seeing you at the next one.
Thank you.
Thank you. Bye.
Thank you. Thank you. Bye-bye.
Sorry I was late. I just got back in.